feature, the onset of symptoms usually 3 to 14 days after infection, and during fever, scarlet form rash may be present that disappears when the arthritis appears. Arthritis is acute, but it is non-migratory. It may be mono or polyarticular, symmetric or non-symmetric, and it affects the large joints of the lower limb. Symptoms resolve within a few weeks to months, and recurrence can occur with subsequent streptococcal pharyngitis. Late onset carditis may occur in these cases, but in the 31% patient in large duration, like from 1 to 18 years after PSRA. Glomerulonephritis and uveitis is very rare. So the proposed diagnostic criteria is that the characteristic of arthritis are that they are acute in onset, symmetric or non-symmetric, and usually non-migratory, and there is persistent or recurrent symptoms, and there is lack of traumatic response to NSAIDs or salicylates. There is evidence of antecedent group A streptococcal infection, and it doesn't fulfill the criteria of ARF. So we manage this patient with aspirin or NSAIDs for arthritis, and the response is definitely less dramatic than ARF. Anti-streptococcal prophylaxis is usually given for 1 year, and during that time we monitor the patient for carditis, and there is baseline and follow-up echocardiogram is done, and if there is no evidence of carditis on echo after 1 year, then we stop the prophylaxis, and the prophylaxis is done by giving penicillin as a first-line therapy, and if the patient is allergic to it, we can use erythromycin. Now another entity is the reactive arthritis. It is also known as Ritter syndrome, and it is an autoimmune condition that develops in response to an infection, especially the GI and genitourinary. And because of its association with HLA-B27 and its clinical overlap with the ankylosing spondylitis and psoriatic arthritis, we have classified it as a type of seronegative spondyloarthropathy. The annual incidence is 30 to 40 cases per 100,000 adults, and typically follows a self-limited course with resolution of symptoms by 3 to 12 months. But it has a high incidence of recurrence, especially in patients who are HLA-B27 positive. The new infection or other stress factors can cause reactivation of the disease. 15% of the patient develop a long-term, sometimes destructive arthritis or enthesitis or spondylitis. Age of onset is usually 20 to 40 years, and reactive arthritis following foodborne enteric infection is equally common in males and females. There is usually an incubation period of 2 to 6 weeks after the genitourinary or gastrointestinal infection. And in 10% of the patient, we do not have any preceding symptomatic infection. The organisms who are usually involved in this reactive arthritis are, there is a long list, the Salmonella, Shigella, Campylobacter, Yersinia, Clostridium difficile, Chlamydia, Trachomatis, Anemone, E. coli, beta hemolytic streptococcus tuberculosis, and even after the vaccination of live vaccine or intrathecal therapy with BCG. Onset is usually acute and is characterized by malaise, fatigue, and fever. Joint involvement is usually asymmetric and usually affect ankle, knees, and hips. Low back ache is in the 50% of the patient, and enthesopathy can be there. There may be tachylitis or sausage chip disease. These are some of the clinical findings. This patient may have scleritis, succinate balanitis, some nail changes, keratoderma balanitis, arthritis, sacroiliitis, and Achilles tendonitis, and some have oral aftersorosis. Keratoderma balanitis, this is the wax, like thick wax on the soles and palm, may be seen in the patients. And urethritis I've already talked about. This picture shows the single metacarpopharyngeal involvement, that is the inflammation.